Hello, good morning, good afternoon and evening, welcome. My name is Catherine Fielding and I'm going to be co-chairing this session using digital technology for TB elimination. As my co-chair Dennis Falzon wrote in 2016, the digital health landscape is poised to be transformed, opening unprecedented opportunities for public health action. Hello, good morning, good afternoon. Over the next 80 minutes, we will have 6 presentations covering diverse approaches of using digital technology, giving us approaches to provide people-centered care and support, improve access and timely access to information, and prevent and treat TB effectively. This will be followed by questions and comments from the audience. We will look forward to these discussions. I'll start with briefly introducing myself and the first 3 presenters, and then pass over to Dr. Falzon. I'm a statistician from the London School of Hygiene and Tropical Medicine, and work on evaluating digital technologies to improve TB treatment adherence. And I'm currently part of the ASCENT consortium led by KNCV and funded by Unitate. Our first presenter will be Dr. Maria Eugenia Castellanos-Reynosa, an epidemiologist and medical microbiologist. Currently, she is postdoctoral researcher at the Global Health Institute at the University of Georgia in the US, and will present on the use of GIS technology to characterize congregate settings with high potential risk for TB transmission in Uganda. Dr. Shibu Vijay, Global TB Director of PATH in India, will present the second talk. He's a medical doctor and public health expert with over 20 years experience in public health systems. He's a core group member of the public-private mixed working group for TB hosted by the Stop TB Partnership. Dr. Vijayan will present his experience of AI-augmented chest X-ray screening and TrueLab for TB diagnosis. The third presentation will be Dr. Manu Matthew, who works as a national consultant for WHO of the Central TB Division, Ministry of Health and Family Welfare in India. He contributes to the development of the National Electronic TB Surveillance and Patient Management System, NIPSI. His presentation will focus on ways of reducing catastrophic expenditure by moving to digital certificate-based approval of direct benefit transfers under the National TB Elimination Program. I'll now hand over to my co-chair, Dr. Falzon.
Thank you very much, Dr. Fielding. This is Dennis Falzon here. Greetings from the Global TB Program of the World Health Organization, where I work in Switzerland. So I'm very pleased to co-chair this session, which, as Catherine has just said, is a very innovative area in TB, and we're constantly in the cusp of movement in this space, and especially has been particularly important during the period of COVID, the COVID pandemic. With that, maybe I can introduce the 3 last speakers in this session. So the first one is Dr. Xiaolin Wei from the Dalalana School of Public Health at the University of Toronto in Canada. Dr. Xiaolin will speak about improving TB patient treatment adherence via electronic monitors and an app versus usual care in Tibet, a pragmatic randomized controlled trial. Dr. Xiaolin is a medical doctor with public health specialty, and he is the Dalalana Chair in Global Health Policy at the University of Toronto. He became a fellow of the Faculty of Public Health of the UK in 2012. Xiaolin has conducted research using implementation science frameworks to change clinical practice and make impacts on the policy level in areas of antimicrobial resistance, tuberculosis control, and diabetes hypertension care. He has published over 100 peer-reviewed research papers and led over $7 million of research funding. He serves as board member and has served as the Secretary General and Vice President of the Union. The 5th speaker will be Dr. Joseph Borzinski from the New York City Department of Health and Mental Hygiene, Bureau of TB Control, United States. Dr. Borzinski will speak about preliminary results of a randomized trial comparing traditional in-person directly observed therapy and video observed therapy for monitoring TB treatment. Dr. Joseph Borzinski is Assistant Commissioner at the New York City Department of Health and Mental Hygiene, Bureau of TB Control. Dr. Borzinski received his medical degree from the University of Louisville Medical School and his master's degree in public health from the Harvard School of Public Health in Boston, Massachusetts. He is board certified in internal medicine and infectious diseases and has worked in the Bureau of TB Control since 1995 and served as assistant commissioner since 2013. He served as principal investigator for the reported study. And the last speaker will be Marco Salerno, also from the New York City Department of Health and Mental Hygiene in New York. And his presentation will be assessing adverse events amongst patients using in-person and electronic directly observed therapy. Mr. Salerno is a data scientist dedicated to advancing programmatically relevant public health research. He currently works with Columbia University, Division of Pulmonary Allergy and Critical Care in New York City. In this role, Mr. Salerno manages large data sets, leads statistical analyses, and oversees research operations for multiple studies. Mr. Salerno has a master's in public health from Columbia University and a certificate in TB research methods from McGill University, Canada. Okay, so with that, maybe we can start the presentation.
Good morning. On behalf of the research group at University of Georgia and Makerere University, I want to present to you today this project called the use of GIS technology and self-reported data to characterize congregate settings with high potential risk for tuberculosis transmission in an urban African area. I confirm I have no conflict of interest to report. So as we know, self-reported data from persons with tuberculosis disease may lead to the identification of hotspots that are locations where transmission of Mycobacterium tuberculosis is intense. Transmission in this hotspot may be the driving force behind epidemic of tuberculosis in Africans. So the aim of this project was to map and characterize geographical locations that may act as hotspots of ongoing transmission. So this project was part of a large study called MATS, Mapping Tuberculosis Transmission, which is a retrospective cohort study that we started on August 2019 in Kampala, Uganda. So as our first point was to enroll patients with tuberculosis disease that was confirmed by microbiology diagnosis, and they provide to us a list of locations where they spent time prior to the diagnosis. So at the moment, we enrolled 41 patients, and the majority of them were men and young adults. Then we collected the geographical coordinates of these locations, and we characterized the type of settings they were. As a third point, we classified as congregate settings, and that meant for us settings in which the participant listed 10 or more persons at the time of their visit, and also as indoor settings as reported by the patient. And as a fourth point, we mapped the geographical location of these settings, and we created heat maps to show the density of this location. Now going into the result, here we show the locations visited by the participants during the 3 months before diagnosis. So the participant listed a median of 8 locations with a minimum of 2 locations and a maximum of 30 locations. But as you can see in this figure, we have a bimodal distribution. That is that some patients listed very few locations to up to 12, but then we have another group of participants that they listed 20 or more locations. And that brings us to our first hypothesis, that is thinking if these patients that are being very mobile, they can be more likely to be infection or more likely to contribute to transmission events. Then in this slide, we show the characteristics of the settings. So we classify our locations into 9 different settings types, for example, workplace, the home or work of the contact, entertainment venues, etc. And you see in the second column, we show of these 41 patients with tuberculosis, how many of them listed this particular setting, at least one. So for example, workplace was listed by 34 out of the 41 patients with tuberculosis. So that was the place more listed. The second one was the home of the work of a social contact of the patient with tuberculosis. And the third one was bars, saloons, or clubs. In the third column, you can see that then we are showing the number and percentage of this location. So for example, in the case of workplace, Some patients listed multiple locations at workplace, and that's the reason we have 88 locations. In this slide, what we did is classify then these 486 community locations into congregate settings and then into indoor congregate settings. So out of the 486 community locations, approximately half of them were considered congregate settings based on our definition of 10 or more people that were present in the time of the visit of the participant. And a quarter of them, that is 58, were categorized as indoor congregate settings. So for us, that will mean a setting that have a higher risk of transmission. In this slide, we are showing the proportion of the 9 different settings that we have, the proportion of them in which we can identify them as indoor congregate settings. So as you can see in this figure, by far, worship centers, like over 60% of them, will be identified as indoor congregate settings. Other settings that also we have some proportion, even lower, of indoor congregate settings will be entertainment venues, school, and healthcare settings. Some characteristics now of only these 58 indoor congregate settings, we have the following. First, 53% of them have 50 persons or more at the time of the visit of the participant. And in 43% of them, the patient reported that they didn't meet with any of their social contact. And in the majority of these locations, the patient visit this place after the onset of cough. And the majority of, in this location, the participant listed that in the last 30 days before their diagnosis, they have visited a median of 3 days, these indoor congregate settings. Now, we were also interested into knowing the time and frequency spent by the participant in this indoor congregate setting. So here we can see that in this matrix, we have the days per week spent in that indoor congregate setting, and also the hours per day when they visit. And as you see, the majority of our participants were between 1 to 3 days per week in this location, and around 2 to 6 hours in a given day. So that means that we consider that is enough time for a transmission event to occur. Then we map these the geographical coordinates of these community locations. And as you can see in the left map, we are presenting all the community locations, the 86 locations. And in the right, we can see just the 58 indoor congregate settings. And I want to bring your attention to this particular square in red. And if we do like a close-up of this area, we have seen that it just comprises an area of around 3 square kilometers. And as you can see, we can see some areas in which we do have dense areas. So that means that clusters of locations, like for example, in this area is more to the bottom part of the map, in which we have like a cluster of many locations in a very small area. And then you can see more into the top, in the north of the map, we can see less density. And even we have incorporated the hours per week. That is when we combine frequency and time of how much the people spend in these areas. So we believe with this type of information, we can add even another dimension to measure the level of transmission risk. So with this, we have the following conclusions. We believe that our project has shown that persons with undiagnosed tuberculosis disease continue to be mobile in the community, and that they visit a variety of indoor congregate settings where transmission may be enhanced. We also saw that these self-reported locations were geographically heterogeneous, so transmission will vary between the city. And we believe that that public health intervention can target these geographical defined locations to reduce hotspot of ongoing transmission. I want to finalize acknowledging all the field and laboratory research staff at Makerere University and Luwa Hospital in Uganda, and also the National Institute of Allergy and Infectious Diseases at the National Institute of Health. And finally, the Epidemiology in Action Research Group at our University of Georgia. And thank you all for your attention to this presentation. Thanks.
I'll be talking about building innovations for public-private mix by bundling two Indian innovations. One is X-ray artificial intelligence, and the other one is molecular diagnosis technology. So on the project background, the idea was to accelerate screening of key affected populations in slum dwellings of Nagpur using newer diagnostic technologies, both screening as well as confirmatory technologies. The project was initiated under a TB Reach Wave 6 support from Stop TB from August 2018 to January 2020. Implemented in 6 tuberculosis unit control as an intervention, and also 4 TB units for comparison we selected. So typically a TB unit in India is roughly around 200,000 population per unit. The focus areas were diagnostic interventions. As I earlier mentioned, there is a radiological screening through artificial intelligence, and then microbiological testing through TrueLab, which is now a WHO approved molecular diagnostic technology. So one is in the private sector, and the other one is in the public sector. So we attempted to do a public-private mix here. So how the public and private mix happened is explained in this slide. So in the private sector, we did a mapping and we engaged informal providers. So again, typically in Indian health system, specifically in the private sector, we have formal and informal sector doctors. The informals are less than fully qualified, though they are mostly Indian systems of medicine or homeopaths or Unani systems and Ayurveda. So they also see patients, but they are not allowed to prescribe TB medication, but they certainly see presumptive TB cases. So what we did a mapping in this intervention ward and engaged the informal provider and provided access for them for chest X-ray screening, which is already artificial intelligence tool enabled chest X-ray screening in the private sector. On the public sector, we positioned this TrueLab testing device in the public sector hospital. And then from there, so the diagnosis happens in the private sector, and then the subsequent follow-up and notification and treatment outcome is the responsibility of the public sector. So just a word on QRI. So it's a solution, I mean, it's an AI-driven solution for diagnostic assistance and detects X-ray abnormalities. Identify 15 common chest X-ray abnormalities, such as consolidation, cardiomegaly, pleural effusion, and calcification. And the TB screening algorithm is a combination of 8 such abnormalities, and then it could predict the likelihood of tuberculosis. And then subsequently, we need to confirm with the bacteriological diagnosis. So you can find more details about this thing in the QRI website. So on the TrueLab, so I explained about the screening tool. Now it's a confirmatory tool. It's the TrueLab is a portable package with micro PCR analyzer, sample preparation, printer, pipettes, and charges. It's a small lab put into a suitcase. Independent infrastructure. We don't need a high lab facility. We don't need air conditioning, air cooling for that. No need of continuous power supply. It's a battery operated device, and it pretty much functions like fully automated. Once it is once the sample is processed, the results will come, and also it enables the results to be pushed through an IT system to the respective stakeholders. So the project process is like that. The presumptive TB cases show up in the clinic of the informal doctor. The informal doctor assesses them clinically, and then if they suspect anything, any lung condition, they can offer a chest X-ray through voucher mechanism. And the patient goes to a chest X-ray facility and gets the X-ray done. And the AA reading will inform the health worker and also the provider saying, hey, there is an abnormality and the patient needs subsequent testing. And the patient, once the information is reached the doctor will inform the health worker, and the health worker will facilitate the sample transportation to the public sector laboratory. And then once the diagnosis is established, the patient is notified, the drugs are given, and we also engage with the local CBU for an adherent support system for the patients. Coming to the results, during the course of this project of almost 1 year plus, we have screened around 10,000 presumptive TB patients registered. Among that, this is all through the informal doctors. Among that, 8,731, that's roughly around 83% of the presumptive cases screened with just X-ray. Of that, 27% of them are screened positive by the X-ray, by the abnormal finding were reported by the AA tool. And within that, roughly around 70% got tested with the TrueLab. That's a confirmatory test. So we found 9% screen TB detected and notified among the screen. 82% of the patients were microbiologically detected. I mean, one of the reasons is essentially most of the diagnoses were confirmed by the public sector TrueNet lab. There were the rest of them were clinically suspected, were evaluated by the doctors in public system, and then they designed it. I mean, then they diagnosed it. So 29 additional TB cases confirmed microbiologically or clinically through AA tool compared to the radiologist reading. So we had an embedded system within to compare both radiology as well as the AI tool and how the diagnostic outcomes are coming out of it. So this is pretty much a crowded slide, I would say. So this clearly explains how the two systems. So we had X-ray facility. So you can also see there are 458 odd X-rays are not read by the machine. It's done by the doctor itself. So if you take, I mean, so that is one arm, and the other one arm is within that AI read, and also AI and doctor agreement and discard. So we see an agreement of no lesion is roughly around 91%. We see a discordance, I mean, the agreement discordance is more than 50% when it comes to an abnormality between a doctor and between radiologist and the machine. Though this was not an evaluation to head-on compare what doctor read versus this, it's not designed, the study is not designed like that. The study was principally designed to look at how this bundling will affect and accelerate the TB diagnosis. But what we found is that in most of the occasions, we found additional cases. The additionality is phenomenal when it compares with with the radiologist conventional reading through this system. We see, and as from an impact perspective, we see 50% increase in microbiological case notification and 20% increase in all forms of notification in 2019 compared to 2018 in the public sector. So this is the same period we compared with the previous year. Informal provider referral system established. So you are not, so the patient pathway will get reduced, like when the informal doctor gets into a habit of searching for tuberculosis and then referring it to public system for confirmation. So that linkages got established. Potential option of screening and diagnosing TB patient in peri-urban and rural geographies with limited human resource in the mission to find missing million TB cases. So that is something, because we have informal provider network, and then we could use that. So I would like to acknowledge the Nagpur Municipal Corporation. Disa Foundation was our local partner who did a lot of legwork and actual implementation at the ground. And Cure.ai is the technology partner on X-ray screening, and Mold Biodiagnostics is the TrueLab partner, which is the confirmatory molecular diagnosis, and eventually Stop TB partnership. Thank you.
So hi everyone, I'm Dr. Manu Matthew. I'm the presenter for today. My topic is on reducing turnaround times by transitioning from paper to digital signature-based approval for direct benefit transfers under the National TB Program of India. I am a part of the team that develops the system and implements it. So a little conflict of interest to show that in good light and analyze it positively. So just to give you some background around this, a direct benefit transfer is a scheme which is by the government of India, which transfers benefits, whether it's financial, cash, or whatever it is, from the government funds directly to the beneficiary's bank account. So that is the concept of direct benefit transfer. And in the National TB Program of India, we have 4 direct benefit transfer schemes for different types of beneficiaries. The advantage here is the processing is done totally electronically through the National Payments Gateway, and there is no intermediary step or intermediary manager who receives these funds. So it goes from the bank account of the government directly to the beneficiary's bank account, while the processing of it is done electronically. Now, for the 4 schemes that we're talking about, it is done through an end-to-end digital processing gateway, which involves 2 systems. One is NICSHARE, which is the National TB Patient Management System and Surveillance System of India. This system generates the benefits according to the rules set by the 4 schemes and allows the authorities to process it. Once that is processed, that information is conveyed to the PFMS. PFMS is the Public Financial Management System. It is a single system by which all funds of government is managed. And based on the information provided from Nikshay regarding beneficiaries and the transactions that has to be done, that interacts with the banking system, and the electronic fund transfer is made. Both these systems are live across the country for all purposes and across all sectors, and that is it's a nationally implemented system. And today's intervention, we're talking about one intervention that we're talking about is the digital signature-based processing for ensuring that transfers are made. And this allows some parts of the processing to be converted into a totally digital-based process. So just to highlight that the DBT-based process is a 7-step process that is starting from the benefit creation in Nikshay, finally to the 7th step of credit to the beneficiary. So there are 3 steps of approvals. 2 of them happens in Nikshay, which is the first system of TB patients, and 1 step of approval happens in the PFMS. And once approvals are done in PFMS, before the DSE-based process, somebody has to take out a payment advice, and that has to be signed by the corresponding authorities. And that paper has to travel between these 2 authorities and then finally to the bank, which will validate that particular payment advice and then make the transaction. So it's effectively like a check before DSE is being applied. So once that constitutes a fairly amount of delay. So once the DSE-based process is involved, effectively that 6th step becomes totally automatic, and the approval in PFMS is also electronic. So whenever the approval is given in PFMS, the corresponding authority has to sign it using a digital signature, and effectively that entire process from 3 to 7 moves automatically with 1 step of the digital signature being applied in PFMS. So that is the entire process change. So because of this, any paper travel is eliminated, and it is done totally electronically. So what we studied in this particular intervention, this is a part of a number of interventions that allow the improvement of the direct benefit transfer schemes in NTP. And we studied a before and after scenario of 1 city of the country, wherein which we were able to initially pilot this particular intervention and see the improvements over time. So this is the city of Mumbai, where there's a large load of cases. Approximately 20 districts were included in this study, and the digital signature was applied on March of 2020. This was just at the time of lockdown, and just at that time where we applied this. And we are seeing an average change in these. This slide is talking about the line is talking about the average processing delay from the Nikshay side, where the approver send it to PFMS, and then finally the endpoint is the credit to the beneficiary. So this is talking about the average delay between those 2 time points. And between before and after March, you can see a fairly significant change in the delay. So before it's around 10 to 15 days on average, and after the digital signature has been applied, it comes to somewhere near 5 to 3 after the digital signature is applied. So because this is electronically validated, it also reduces the rejections, and as a result of which the number of benefits that were able to be transacted, that also fairly significantly increased by an order of 2. So before this, the process was implemented, we were able to transmit around 10,000 benefits, 10,000 transactions in these particular districts. But after implementation, we were able to transact around 22,000 benefits per month on average. So coming to some recommendations from this, we were able to, by implementing digital signature-based processes, we were able to eliminate significant paper-based steps in the transaction process. And this allowed the reduction of turnaround time from 10 to 15 days to 3 to 5 days. And this also allowed us to reduce the number of rejections and thus increase the number of successfully transacted benefits from by an order of 2. So 2 times the number of benefits were transacted. And because the digital signature-based process is transparent, many people can audit that particular activity, and it is fairly difficult to forge any of these processes. This also increases the reliability, security, and transparency of the system. So the next challenges or the next steps that we are right now dealing with is to scale this up across the entire country. This is a mammoth task. This involves approximately 3,400 officials moving from a paper-based process to a digital signature-based process. So a huge amount of change management, a lot of training and onboarding of these new officials into this process. At the moment, as we speak, between June and September of this year, we have managed to onboard approximately 40% of the entire country on this process. So it's an ongoing process, and we hope to be complete by this entire year, by this year end. And the continuous training and onboarding is going on, and there is a continuous review of the process, identifying where are bottlenecks of the process, and giving feedback and handholding to all the officials and the field staff on this particular activity. So that is all from me for this presentation. Thank you. Thank you to all the partners and the stakeholders involved in this entire process. The Ministry of Health has been continuously stewarding this activity and moving this forward. Thank you.
Good day, everybody. My name is Xiaolin Wei. I'm a professor from the Dalai Lama School of Public Health in the University of Toronto, Canada. So my topic here today is to evaluate the effectiveness of using electronic monitors to improve tuberculosis patients' treatment adherence in Tibet, China. So Tibet is a very special setting. So it's a high plateau, about 3,000 meters above the sea. It has severe weather. Travel is a big hurdle in Tibet, and people are sparsely populated. Traveling from one place to another place normally take 1 day or at least a half a day. There's also a shortage of health providers, so it's very difficult for patients to get care or get support. So in the reality, lots of patients would lose to follow-up during their treatment, and DOT, the directly observed treatment, is not properly implemented. So we are doing this project to evaluate whether using medication electronic monitors with cloud connections will improve patients' adherence to their medications. So we designed a multi-center individualized randomized control trial. We aim to recruit 300 patients. Right now, we have already recruited half. So the technology is based on this electronic monitor. So it packs at least 2 months dosage of the drugs for patients. So that is a blister-based drug. Once the box is open, the patient will take 1 blister for 1 dose. There's a SIM card located on the cap of the box. So it will record the opening and then send a message to the cloud to store the time of the opening. It also has a speaker, which is timed to remind patients to take their medications. The battery of the boxes can sustain it without any battery, without any power supply for at least 48 hours. The box also is connected with WeChat app. And then the WeChat app will fit into the cell phones of the patient and also the health providers. So here you see that we normally would have a treatment supervisor in the village who is a village doctor, and patient and doctor can be connected via the WeChat app. And then the doctors in other places at the TB dispensary and township hospitals can also connect with patient with the WeChat. So they would know about the patient and treatment adherence history and know if there's a problems, if there are any problems happen. they would talk with patient and seeing that problem comes from a lack of support about the side effects, etc., and then can fix the problem. So if we, in the program, if there are the 3 doses have been missed in a row, and then the video doctors can use the WeChat to do the video directly observe treatment with the patient. We call VOT, and then to ensure the medications are properly taken. We randomize the patient into the intervention and control group. So in the intervention, the patient may use the box, etc., as I just said. In the control group, patients are also being given a box which pack their medications. But all the boxes are deactivated, so it only has function of recording each opening of the boxes, so we know the treatment history of the patients. But it does not have the function of reminding patients. It does not have the function of connecting with the cell phones of the patient and the treatment supporters and other health providers. So the primary outcome is to look at treatment adherence measured by the end of the course. So poor adherence is termed like missing over 20% of doses at a monthly basis. We're also looking at treatment outcomes and general patient adherence regarding the total doses missed and the loss to follow-up rate as a secondary outcome. We have already passed the ethical approvals from Canada, University of Toronto, and from the SHICAS, Tibet. There's a couple implementation issues because here the advantage of this project is that we get involved of the government and the policymakers from the beginning to let them understand and also be on the team, see the importance of using this new technology to improve treatment adherence. Through the project, we also have to improve the capacities in Tibet in terms of the design, implement, and improving the quality of care. We also have the technical support and also the free support, get free electronic boxes from the company, which is providing this technology. So in the long run, we are looking at the government will be dedicated to purchase these boxes for all the TB patients in Tibet. So those are the photos about our kickoff meetings and trainings. So in the trainings, we get all the TB doctors at county, township, and region level for the training. We also visited the patient's home to look at how the boxes are functioning and if the patient can accept the boxes and how easy and feasible to use WeChat over their cell phones. For example, that is the story taken on the left is that we are looking at a box in the home that is supported by the person in the patient's son. And he told me how they, the boxes, how they use the boxes in terms of get information about medication and how they use a cell phone or WeChat to get the knowledge from the video doctors and other doctors when there's a problem. And then the person on the far left is the video doctor, and this person is the director of the SHICAS CDC. We did a very preliminary analysis before the trial ends to show at this moment, we can see that the medication adherence in general for all the patients in the intervention arm is about 99%, compared with only about 34% in the control arm. So that has been a huge difference. But we haven't collected the information based on the monthly basis, so we wouldn't calculate the primary outcome once the trial ends. So that is a first clinical trial regarding using electronic monitors in the low and middle income countries to our knowledge. I also know there's similar trials are doing in Vietnam. But we are looking at this trial in a very special condition. We are also designing all the activities according to the routine TB care, so that can be easily taken up as a routine work after the project. Also, the government is dedicated to purchase all the boxes to the TB patients in Tibet after the trial results demonstrating success. And also, it can enable VOT when it's necessary, and the VOT will not be for everyone, but only for those who are in the need for VOT. We also had an impact of the COVID because of COVID, lots of resources have been put into COVID control, and also there's a problem for patients to travel to the city centers for testing about a cough because they will be afraid of COVID. So all of this have delayed the process, but we're looking back to resume to normal right now, and we hope we can finish by the next February for all the patient recruitment. And then the next stage will be we're conducting a process evaluation to understand how patients look at feasibility and how the product has been adapted in different centers. Okay, thank you and welcome for any questions.
Good morning. I'm Joe Brzezinski. I'm the director of the TB Control Program in New York City. On behalf of my colleagues, I would like to thank the conference's program committee for this opportunity to present the preliminary results of our randomized trial. I have no conflicts. The use of electronic forms of DOT is an alternative to traditional in-person DOT for monitoring tuberculosis treatment is increasing. The evidence supporting this approach is somewhat limited. Starting with a hypothesis that electronic DOT, or eDOT, is non-inferior to traditional in-person DOT for monitoring treatment adherence, we conducted a randomized 2-period crossover non-inferiority trial to evaluate whether eDOT can attain a level of treatment adherence at least as favorable as in-person or IPDOT. As shown in this figure, following randomization, participants aim to complete 20 medication doses with one DOT method, then switch DOT methods for another 20 doses. Following these 2 crossover periods, participants chose the method of DOT they used for the remainder of their treatment. This study was conducted in 4 TB chest clinics in New York City. Our primary outcome was the difference in the percentage of non-holiday weekday medication doses completed when observed by eDOT versus IPDOT. Analysis was restricted to patients with 10 or more doses observed with each DOT method in each crossover period. As noted, participants aimed to complete 20 medication doses with each DOT method. During IPDOT, participants were able to choose between clinic or community-based DOT. With eDOT, participants could choose either live video conferencing or recorded videos. All medical care was provided according to the program's case management policies. Patients were eligible if they were 12 years of age or older, had a confirmed or clinical diagnosis of TB, had a residence available to staff, and had no plans to move. We did not enroll patients taking an injectable medication, those with comorbidity or circumstance that precluded a physician's comfort with eDOT, or a disability that prevented their use of eDOT. We used 4 analytic approaches to test for non-inferiority. In the intention to treat analysis, the eDOT method of each dose was represented according to the participant's randomization assignment. The per protocol analysis was restricted to patients who completed 100% of their doses according to their randomization assignment. The per protocol 85% analysis was restricted so that a minimum of 85% of each patient's doses complied with their randomization assignment. In the empirical approach, the DOT method for each dose was represented according to the method undertook by a patient, regardless of study assignment. Patients in the empirical analysis were the same as in the intention to treat analysis, except that the representation of DOT method differs. A few notes regarding the statistical models used. Each medication dose scheduled to be taken had a binary outcome where staff observed the patient completely ingesting the dose or not. These binary outcomes were modeled with a logistic regression model that estimated their association with whether the dose was observed under IPDOT or EDOT, while adjusting for crossover period, randomization group, season, and whether the previous 2 doses were completed or not. In addition, we included patients nested within each clinic site as random effects to control for expected correlations. We subtracted the percentage of doses completed under EDOT from the percentage under IPDOT. With a bootstrap technique, we estimated the variation of this percentage difference with a 95% confidence interval. In the protocol, we set a limit of non-inferiority as plus 10%. As such, the percentage difference between IPDOT minus EDOT could be no more than plus 10% in order to conclude that EDOT was non-inferior to IPDOT. This table summarizes the demographics of all 216 persons enrolled in this study, including the 173 participants included in the intention to treat and empirical analyses, the 43 participants included in the per protocol analysis, and the 138 participants included in the per protocol 85% analysis. Overall, participants ranged in age from 16 to 86 years. The majority of participants were male, non-white, and non-US born. Over half were employed at the time of study enrollment. And a majority possessed or had access to a video-enabled device prior to enrollment in the study. This table provides the total number of weekday doses that were scheduled for DOT. Doses staff observed the patient completely ingest, the percent of doses taken with IPDOT and EDOT. The second row from the bottom provides the percentage difference between IPDOT and EDOT, along with the 95% confidence interval obtained through the bootstrap technique. You can see the percent difference between the 2 DOT methods range from minus 1.8% to minus 4.1%, which falls below the non-inferiority delta of 10% or less. This forest plot illustrates the percentage difference for the 2 DOT methods. On the right side, you can see the green line, denoting the 10% non-inferiority margin. The results of the per protocol 85% and the empirical analysis illustrate that EDOT is not inferior, yet not superior to IPDOT. The results of the intention to treat analysis would indicate EDOT is non-inferior and superior to IPDOT. The primary limitations of our study were the sample size and broken randomizations. We did not reach the sample size as outlined in the power calculation. Our goal was to enroll 256 individuals. We enrolled 216 participants. Patients who only wanted to use EDOT contributed to a high number of non-enrollments. Further, the broken randomizations reduced the number of participants included in the per protocol analysis. The rate of broken randomizations was similar in both study groups. As you can see in the graph on the right, the more than 75% of patients had greater than or equal to 85% adherence to randomization. The per protocol 85% model included more patients and gave us a more robust sample. To conclude, we found electronic DOT to be non-inferior to in-person DOT as an approach for monitoring treatment adherence. This finding was associated with a statistical confidence of 95% and was consistent across intention to treat per protocol 85%, and empirical analyses. We estimate program staff observed patients ingest 1.8 to 4.1% more medication doses when EDOT was used. Thus, EDOT may be as effective as traditional DOT methods for improving treatment adherence, clinical outcomes, equity, and patient-centered care. We have many people to acknowledge, most especially the patients who agreed to participate. Thank you for your attention.
On behalf of my colleagues at the New York City Bureau of TB Control, the CDC, and Columbia University, I would like to thank the program committee for the opportunity to present data on assessing adverse events among patients using in-person and electronic directly observed therapy, or DOT. My name is Marco Salerno, and I am a data scientist at the New York City Department of Health. I have no conflict of interest to report. Telemedicine provides programs with the ability to connect patients with providers at a distance using mobile telecommunication technologies. Telemedicine can help to reduce the burden on patients to travel to healthcare centers, increase access to healthcare services, and facilitate health equity. As noted by my colleague, Dr. Brzezinski, in his presentation about our study's primary objectives, we partnered to conduct a randomized two-arm crossover trial to compare in-person DOT with electronic DOT for TB treatment in 4 New York City Health Department TB clinics. For the remainder of this presentation, I will refer to in-person DOT as IPDOT and electronic DOT as EDOT. As a secondary objective, we assess whether EDOT is an appropriate adherence support method for patient safety. Our study eligibility criteria included patients with 12 years or greater in age and with confirmed or suspected cases of TB. Relevant definitions for this analysis include adverse events, or AEs, were reported signs and symptoms associated with anti-TB medications and health-related issues while undergoing TB treatment. Health-related issues were reported events that were not a result of TB disease or TB treatment. In terms of data collection, participants reported AEs at the beginning of DOT sessions or during monthly clinic visits. Upon enrollment into the study, participants were given instructions for how to report AEs and what types of problems to report. Study coordinators prospectively documented AEs on a specific study data collection form. Clinicians reviewed the AEs study forms and graded symptom severity. New York City principal investigators reviewed and signed all completed forms. AEs were analyzed by DOT method used by patients immediately prior to the reporting of the event. We looked at various outcomes for this analysis, including AE type, AE frequency, and AE severity, the time between initial AE report and discussion with a medical provider, and clinical action in response to AE. Of the 216 enrolled participants, 63 or 30% experienced AEs. Patients may have reported multiple AEs. In our cohort, 63 patients reported 87 AEs. When comparing AE to non-AE patients, notable demographics include 42 median years old for both AE and non-AE patients. More females reported AEs, 49% versus 29%. Similar proportions of non-US born for both AE and non-AE patients, 91% versus 90%. More Hispanics persons reported AEs, 40% versus 30%. In terms of DOT modality use, 40 AEs were reported by 30 patients while using IPDOT, whereas 47 AEs were reported by 40 patients while using EDOT. 7 patients reported multiple AEs while using IPDOT or EDOT. The following table includes 3 categories of data in the left column. Most commonly reported symptoms, severity of adverse events, and adverse event management. In the first category, you will note most commonly reported symptoms were similar for both EDOT and IPDOT adverse events. In the next category, you will note few adverse events were graded 3 to 5, 13% cumulatively. Most of these events were graded 3. Few patients were hospitalized, 10% cumulatively. One patient experienced a life-threatening event. The time between symptom onset and patients' discussions with providers was similar by DOT method. 1 median day for IPDOT and 1 median day for EDOT AEs. Some EDOT AEs required more time as demonstrated by the greater interquartile range. The most common type of first encounter to discuss AEs for IPDOT were non-routine clinic visits with 55%, routine clinic visits with 23%, patient-initiated phone calls with 15%. Whereas the most common type of first encounter to discuss AEs for EDOT were non-routine clinic visits with 44%, program-initiated phone calls with 26%, and routine clinic visits with 17%. Ultimately, no patients were switched from EDOT to IPDOT due to AEs. Our findings indicate adverse events, including medication side effects and health-related issues during TB treatment, affected almost 1/3 of participants in our study. The types of adverse events and the level of severity were similar across DOT methods. The time from reported symptoms to medical attention was similar for both in-person DOT and electronic DOT. Lastly, I wanted to take a moment to acknowledge the individuals who participated in the study. I would like to also acknowledge the tremendous effort put forth by the following individuals on the slide. Thank you very much for your time and your attention.
Presenters. They were fantastic presentations. We've also had a very large number of questions come through, and so thank you very much to the audience. What we're going to do now is ask each of the presenters 2 questions, and we'll rotate round. And if we have an opportunity to go around more than once, then that will be fantastic. So Maria, I'm going to start with you. You had many questions, but I've just chosen 2 for you. So the first question was, thank you, Maria, for the nice presentation. This is from Christian Mulder. Was there any association between the bacterial load or symptoms of the patients and the locations and time spent the patients visited prior to diagnosis? Maybe the more sick patients are less mobile.
Yeah, thank you for the questions. So actually, all our patients by just inclusion criteria, all of them were 2+ or 3+ in the smear grade, or like expert high, because actually we want to collect their isolate to do genome sequencing. So I think everybody has the same infectious level. But it's true that we are still pending the analysis to see if actually the symptoms can be the reason of why some patients were more mobile than others.
Thank you, Maria. It sounds like you've got a really rich data set there.
Yes.
Your second question, it's being asked by Zemadou from KNCV TB Foundation, and also from Lucy from the Forum Institute. So the question is, how can GIS data be integrated to TB program to stop the spread of infection? And really from Lucy, it was, what are the next steps after mapping the clusters?
Yeah, thank you. So what I present here is just really a section of our project. We are at the same time, as I just mentioned, collecting the isolates, and we will do genome sequences to actually have the molecular epidemiology part to actually see if we have another confirmation of similar isolated between different persons. But we believe, and also the other thing I didn't mention is we are also collecting the telephone data from the patients of the 3 months before diagnosis. So all of our patients were newly diagnosed, and we are trying to collect the data of the 3 months before the diagnosis. So with all this, we are thinking that by integrating cellular telephone metadata with the self-report data and also with the whole genome sequence, that can really help us to infer transmission networks and hotspots. And then the point will be that for the public health intervention, that then with this information, the TB control programs can use the common strategies as TB screening, active finding, more in a more specific and tailored way.
Thank you, Maria. Thank you. I'll now move over to Dr. Shibu Bijan. You have also many questions, and so I've just chosen two. So the first question is, what is lost to follow-up rate in your project after patients were referred between different service delivery points? Was sample transportation implemented?
Yeah, so we didn't actually track the cascade fully, but to say that if internet was up and running and if the software was no issues, the X-ray turnaround time was, the reading turnaround time was roughly around a minute. And then the patient will be asked to deposit the sputum next day through a sample collection transport system. So, and if again the lab is functioning well and the lab technician is showing up at time, then it is roughly around 1.5 to 2 hours, the patient will get a result. So in an optimal situation, this is within less than 24 hours, patient will be diagnosed and put on treatment.
Thank you. And your second question, thank you, Shibu, for such a wonderful presentation. It is indeed call of the hour to reach the unreached. Hashtag QLab is the answer to that. In the process, what are the challenges you faced? Secondly, this is probably would be turned into a policy for NTB. How can this be integrated into the private sector?
Okay, so one of the challenges is that there were different versions of this technology while we were running the project, because it started with a particular version, and then it had some hardware requirements, which includes internet capacity. It includes the compatibility of the software with certain devices of software, which took a while to settle. In a couple of months, we settled and then moved into a new version. And certain X-ray facilities won't agree on putting another software on the top of their existing facility. So it's a convincing, there is a convincing window to get them convinced over, okay, this is not going to corrupt my systems. So sometimes we have to procure another systems to put the X-ray for reading through AI, don't coupling with their existing hardware. So that's one of the challenges. And the other challenge was the radiologists, Radiologists Association, the Professional Association of Radiologists, posed the significant pushback in the initial days of the project, thinking that it's undermining their capacity to read the X-rays because technology is replacing their capabilities. So we also did a lot of convincing meetings and asked them to have a separate evaluation under their association, professional association leadership, to get a hang of this technology. So these were the two critical challenges. So later on, then StopTB evaluated these technologies, and the Cure AI stood high among that. And then Government of India approved us to procure that under the Global Fund grant, which we are doing in private sector. So that's been now rolled out in 4 districts, and we are hoping that results will give us confidence and give NTP confidence to scale up that innovations across India. Thanks.
Thank you, Dr. Vijayan. Okay, now moving on to Dr. Manu. So I selected a couple of questions for you. The first one is, thank you for your presentation, Dr. Manu. As your team looked at decreased turnaround time for processing payments, have you looked to see if there is a corresponding decrease in loss to follow-up among patients?
Right. So this intervention that we've implemented is less than 6 months old. So it's not time enough for us to assess how well loss to follow-up and outcomes have changed. But data is there. We are tracking that information. Maybe just wait for another 6 months. We will publish that information. That will be available.
Thank you. So we look forward to seeing those data presented at the next meeting. So your second question is, first of all, thanking all the panelists. And then directly to you, Dr. Manu, just wanted to understand the applicability of the initial system in rural settings. As I understand, there is an issue around financial inclusion. What is the interventional plan to reach out to such patients who are not part of the formal banking system?
Right. So recently, this is not directly interventions that the Ministry of Health does, but there have been significant increases in the financial inclusion over the last 1 year or so, especially with the COVID situation that has picked up quite a bit, especially in terms of electronic digital transfers. So one intervention around that I would like to highlight is something called the Indian Postal Payments Bank. So effectively, that intervention is allowing postmen, which is spread across the country, even in rural areas, it's not a problem. So a postman can go to the doorstep of a beneficiary, depending upon the details that we share. Let's say Nikshay shares information of a particular beneficiary whom we are not able to open a bank account or collect bank accounts. We can share that details with the postal bank system, and that the corresponding postal department personnel, that is a postman, will reach out to that particular beneficiary at his doorstep using Aadhaar and other identification available with him. They will open a payments bank account and make it available digitally. So that is an intervention which is available across majority of India, and we are trying to form a partnership with the postal bank so that this can be made available to such rural patients as well.
Thank you very much. Thank you. Over to you, Dennis.
Thank you very much. So maybe I can start with questions to Dr. Gzay. So there are a number of questions for you, and I'll just start with two so that we have time for the rest. So one question which came from Pranati Das of the William Clinton Foundation is what proportion of patients would likely have been excluded from participating owing to ignorance about audiovisual platform, and what were the challenges in educating patients about video supervision?
Thank you very much for the question. So we do not have a completed record right now because the trial is ongoing. So right now it's about 60 to 70% who are eligible to be included are finally included. There are lots of reasons, mostly are practical reasons. For example, the patient had to live in a dormitory in the school that they cannot use the box. Or the patient has to be hospitalized. Or sometimes was that during the COVID period, the patient was not timely recorded, and then we have to pass this patient. So we are going to have a much detailed analysis after all the data is complete.
Thank you. Another question is about whether you did any studies to correlate the electronic signal from the box with actual intake of the medication.
We have a checkpoint is that when the patient finished all the medications, they will bring the box and also bring the used blisters within the box to a doctor to be numbered. So by numbering the finished blisters, the doctor would know if the patient had taken the drugs or not. And then this information will feed back into the system to correct if there's any mistakes. So I think the most the likely mistake will be patient open it but did not take the medication. So that is the way we are doing to double check this.
Thank you, Dr. Gzay, for the answer, and thank you, Dr. Avinash, for putting the question. So I turn now to Dr. Brzezinski. There are two questions for you. The first is, why adjust for whether the previous two doses were observed to have been taken? And that's
Sure.
So Yates at Imperial College London.
Yeah, thanks for the question. The two previous doses account for carryover effects. This was essentially an autocorrelation between dose outcomes over time, and the carryover effects were significant predictors in our model.
Right. And the other question, which is a bit related to this from Srinath Satyarana, is about how are carryover effects addressed in the study?
So carryover effects are accounted for with lag terms representing dose outcomes for 1 and 2 days before the present dose.
Okay. Thank you. And I have two other questions for the last speaker, for Marco Salerno. So how were the EDOT sessions in average, and what platform was used?
So the EDOT or EDOT platforms used were two. One was Skype for Business for synchronous or live video conferencing, and one was SureAdhere for asynchronous or recorded video. Now, I don't have specific data points on how long the average session was, but it generally ranged from about a minute to a few minutes.
Thank you. And another question for you is about how did patients report adverse events in the EDOT?
So patients reported adverse events either at monthly clinic appointments or at the beginning of the EDOT video before ingesting medications. They would report through the video platform.
Okay, thank you very much. So maybe because we have still a bit more time, I have some additional questions to Dr. Wei, and I can maybe put those questions to you. So another one was about what is the extent of response of healthcare workers for the alerts regarding the missed dose? This coming from Dr. Prutu Thakur from the uni.
Thank you. First, I want to clarify the question. So I do. Is that about what is response from the doctor regarding if a patient missed the dose during the patient and the doctor meeting every 2 months? Was that the question?
Yes. So it's really a question, I guess, about how the clinicians responded whenever there was a signal of a missed dose. I think that's
normally that will the doctor will do education of the patient regarding what the reason missing the dose, and then there would be the regimen will be the patient will continue to take the doses. If, for example, if that is missed less than a certain number. If that's missed over a certain number, the patient had to be tested, might be go through a different treatment. So all the procedures are according to the national guideline.
Okay, thank you. And then another question from Helen Stagg, University of Edinburgh. Are you planning to look at the adherence patterns in your patients and the control versus intervention arms? Example, changes in adherence over time and presence of big versus small gaps.
So we are going to looking at the adherence on a time at the individual level on a daily basis. So we want to know that how this technology changed patients. Specifically, we are doing process evaluation. So we are interviewing patients, providers, and to see their reactions to this. I think the quality information will be much richer, and then will give us more ideas how to implement this at a wider scale.
Thank you very much. There's a question which came just now for Dr. Manu about whether the NICSHI data are available publicly, of course, masking the identifiers. Dr. Manu, maybe?
No, the notification aggregate information is available on the public domain. You can access it from reports.nikshay.in. But any further information, whether it is person identifiers or patient level data, is not available publicly to the program managers internally.
Okay, so thank you very much. There was one other question which was addressed to all of us actually, and this was about about whether the individual digital interventions, what are your thoughts about integrating all such interventions into a comprehensive system, including of all of these and more? So this is about kind of the questions about end-to-end solutions. And I wonder if each of you could say very quickly what you think about that, starting in the same order that we had the presentations. We have 5 minutes till the end of this session. I think it will be a good way of trying to wrap it up. Thanks. So, yeah, 20 seconds each.
Oh, wow. Thank you. I think that definitely we have to integrate all of these and not work like in silos in each of them. And I think in the case of what I presented, I think the use of GIS technology is something that has been shown in the past. This is not new. That can be really help to identify a hotspot. And I think the TB control program, not in such a difficult way, doesn't have to be like so much detail or high resolution that we're doing. It can be starting to be used to really tailor the limited resources that sometimes the program have to identify these high risk transmission places.
Dennis, do you want to call out the persons?
Yes. So I think the next was sorry, Manu, right? Shibu, sorry, Shibu.
Dr. Shibu.
Yeah, so now that we are having technologies which is AI augmented for screening, and then the diagnostic systems are linked with the real-time notification systems, we have two data points which clearly flag the probable cases, then confirmed cases, and then we have systems for adherence. Then, I mean, we should worth it trying to bundle all these things together to reimagine the TB care. And that itself is also flagged the hotspot stuff, what Maria mentioned in the initial presentation. What we are lacking, perhaps, a clinical decision support system, which is automated to generate a prescription. Probably that's the next generation of AI, of digital thought process within the TB domain. Thank you.
Dr. Manu, very quickly.
Hi, sorry, I asked the question, so I might.
Sorry, I didn't realize.
So in Nikshay, we have a comprehensive system, including GIS maps, adherence monitoring, direct benefit transfer, surveillance for the patient from notification all the way to treatment outcomes. So we have one system running across the country, one system that integrates all these solutions together. Just wanted to mention that.
Thanks very much. Dr. Wei?
I think my suggestions are two. And the first is that we should strengthen the primary care providers, the health system, because they have to deal many things with many new technologies. So they should have the capacity. The second thing, we should integrate with other diseases, especially diabetes, right now COVID, other respiratory disease. We should not use single technology for single disease. Over to you. Thank you.
Thank you. Dr. Burzinski?
Sure. I think with our study, we showed that with technology that's pretty easy to use, the intervention was effective and also provided a safe way to have contact with patients. We were able to report adverse events on time. And in data that we haven't shown here, in our study, we showed that it's a cost-effective intervention. It's really preferred by patients. I think that the technology that we used with electronic DOT has really proven itself to be an effective strategy that helps patients in many ways.
Okay, thanks very much. I think the evidence, right, of effect of these end-to-end solutions will be very important. Marco?
I would just quickly echo what Dr. Brzezinski just mentioned in his ideas. And then I would further go on to say that some of the EDOT platforms and interventions that we mentioned are currently being implemented in New York City and other places in integrated solutions.
Catherine?
Great, thank you. So it leads me to close this session. I'd like to very much thank our 6 presenters for their fantastic presentations, and also to the audience. We've had a large number of questions. We hope that we've managed to capture the spirit of all the questions, and thank you again to all the whole of the audience, and look forward to a next similar session like this next year. Thank you.
Thank you.
Thank you.